A very good afternoon to all. I would like to thank Dr. Kudlu sir, Sonu Goyal sir, and the entire AIOC team for having us a part of this session. So I'm just going to give a very quick and a short talk on tips and tricks for a perfect PRK. So we do know that PRK have a lot of advantages, which we don't need to go right now. But it did go out of work because of two reasons, which is one is the severe pain and second is the corneal haze. Now let's look into the first issue, severe pain. It is because of the exposure of nerve endings, enhanced spontaneous activity of injured nerves, and release of prostaglandins and neuropeptides. We do have BCLs, but we do not have any active mechanism. Topical treatment can lead to surface toxicity, and oral can lead to systemic side effects and limited maximum daily usage. So can we make a topical pharmacotherapy safer for PRK management? What did our group do was we devised a technique which is ketorolac soaked BCL, where we took the BCL packet, soaked and injected the ketorolac solution 0.5% into this packet, preservative-free, suspension-free, and waited for 20 minutes. And after 20 minutes, as soon as the surgery was over, it was placed on patient's eye. So post-operative, what we saw was that if we used the conventional BCL, the scores were around 8 to 10 on average. But if we use a ketorolac soaked BCL, the pain on the Wong-Baker pain scale came down to 2, which is quite a good thing for PRK. And a lot of times they come, second day they come with a crystal clear eye as if they had got a LASIK done. So the second one is corneal haze. This is how the normal healing happens. Whenever you do a PRK, there is activation of keratocytes, and then there is formation of myofibroblasts, and then they apoptotize to get a normal cornea. But in inflammatory condition, there is excessive formation of this myofibroblast and fibroblast, which leads to aberrant collagen, which leads to formation of haze. So now how do we do it? What do we do? Our group found that if there is a preoperative inflammation present, then post-operatively, these patients are at a higher risk of haze in spite of when you have used mitomycin C or if it's a lesser depth ablation. So we devised this perfect protocol where what we do is we devised a risk scoring system. Preoperatively, if there is a higher inflammation, which you can take with OSDI scoring, or if the patients have low vitamin D, or then if the patient has low vitamin D, then also they are at higher risk of developing haze post-surgery. So to look at vitamin D is extremely important. If the patient have history of contact lens intolerance, that means it's an unhealthy ocular surface, that means it's inflammation, and you would like to treat the patient before taking them up for surgery to reduce the haze for them post-surgery. Meibomian gland dysfunction is also a sign of inflammation, so you need to treat them before taking them up for surgery. And post-surgery, you need to ask them about the working environment, because if they're working outdoors, they are at higher risk of developing late onset corneal haze, and you have to instruct them about the working condition, and they have to use UV protective sunglasses to prevent haze. So if we divide the risk scoring system in less than 5, 5 to 10, more than 10. If it's less than 5, you can take the patient up for surgery. But if it's moderate to high risk, before surgery, treat them with a short course of steroid, cyclosporin, and treat the vitamin D, and then take the patient up for surgery. Intraoperatively, look at the epithelial tightness. If you're removing it with manually, if it's loose, that means it's inflammation. If it's intraoperative excessive secretion, that means it's a sign of inflammation, and post-surgery, you need to keep them on higher steroids. And ketorolac soaked BCLs do take care of the inflammation, so we are at ease that, that will take care of some amount of inflammation and optimizes the wound healing. Low risk, you can go ahead with your normal treatment regimen post-surgery. But if the patient had a high-risk score to begin with, post-surgery, the first choice of steroid would be a prednisolone for 4 weeks, followed by loteprednol for 8 weeks in a tapering dose with sodium hyaluronate, cyclosporin for 6 months, and treat the nutrition according to the WHO guidelines. And if it's an if the epithelium was extremely loose and the secretions were higher, please add a tablet doxycycline for 15 days for this patient. So we can predict, examine, treat, follow up the patients for having a perfect PRK for these patients. Thank you.